Okay, hi, I'm Benson. I work with Ellen, and I'm going to talk to you about mainly just club feet. I could talk about the other feet too, but that'd be boring. So, really quick, club feet. This is the fancy Latin name. I'm just going to go through, chief complaint, history, exam, diagnosis, imaging, treatment, follow-up. This is a picture of Mia Hamm. She was like the captain of the U.S. soccer team back in the 1990s, early 2000s, and U.S. soccer, women's soccer is making a big deal these days, so pretty much every girl watched Mia Hamm play, and the reason I have a picture of her is because she had clubfoot too, and so clubfoot's like no big deal usually, all right? This is Kristi Yamaguchi, she's an Olympic figure skater, she had clubfoot. That's Troy Aikman. I think if you Google people with clubfoot, these famous people show up. And so mostly just idiopathic clubfoot, sometimes just postural, self-limiting. Then you have these other reasons to have clubfoot, like syndromes or some neurologic thing like Spina Bifida. Okay? Basically, it's 1 in 1,000. It's pretty common, and mostly in these Polynesians, Hawaiians, boys more than girls, 50%. Half the time it's bilateral, and there's a bunch of reasons to have it. There's like a bunch of genetics behind it and multifactorial. Intrauterine positioning, things like that. So basically, I think the way it works is usually the baby comes out of uterus, and then the OB-GYN passes the baby off to the pediatrician, and then the pediatrician examines the baby, and they go, oh, that's a clubfoot. And then the orthopedic surgeon will get a call and be like, I think this baby has a clubfoot. And then the orthopedic surgeon will be like, oh, okay, send it to my clinic next week, whenever they get discharged from the hospital. That's usually how it works around Morristown, right? And then like in other parts of the world, these babies might just be born, and then like 2 months later or 2 years later, they'll like go to some doctor and they'll have clubfoot, and it'll be like a neglected clubfoot by then, right? Because it's been 2 months. So usually diagnosis at birth, it's a clinical diagnosis. It has no association to DDH, a real clubfoot. And if it is presenting a little bit later, the mom's just gonna be like, oh, there's a foot problem, my child's feet turn in, and then they might say something like, my family member had this too, okay? You can have intrauterine diagnosis. You can do an ultrasound, usually around 12 weeks gestational age. You'll see it. That's an ultrasound of the clubfoot. Usually it needs to be on sequential observations because, just the kid's positioning in the uterus, you can maybe think it's a clubfoot, but you're not sure. So usually if you see it more than once, it'll be a clubfoot, like 3 times. It doesn't really, I guess it doesn't really have much like prognostic value, but I guess some parents just want to know if their kids have a clubfoot before they're born. Like I said, it's a diagnosis of exam, clinical exam. So you look for 4 things. The baby's going to come out of the uterus. You're a pediatrician. You're going to look at it, and you're going to be like, oh, I see your kid's foot. It's got some cavus, which is this red line here, right? You see this red line? That's cavus. The forefoot is starting to plant or flex on your hind foot. You have adductus, right? Right? The forefoot is turning on the midfoot. Then you have some varus, subtalar varus. The subtalar joint's a hindfoot thing, so you have to look at the back of the leg, but that's going to be some varus. And then you see equinus, which really just means that the toes are pointing down, like you're a ballerina or something. So you look for those 4 things, and you're like, oh, that has those 4 things, so it's clubfoot. And then there's things called posterior heel crease, and you have the midfoot crease, posterior heel crease. And then you have an empty heel pad sign, right? You're feeling for the heel bone, but you don't feel it. It's just soft there. You don't feel the heel because it's turned in a different direction. So it's an empty heel pad sign. You're gonna see all these creases: medial crease, posterior crease. Those 4 things, and it's clubfoot. Sometimes it's just metatarsal adductus. The orthopedic surgeon will get a phone call from the pediatrician, be like, I got clubfoot, and then they see it. It's not clubfoot. It doesn't happen a lot, but it's okay. Better safe than sorry. You'll see an empty heel pad sign, midfoot crease. You can palpate the talar head on the lateral side of the foot. And also, you're going to notice that the calf is usually smaller and the foot's smaller on the affected side. And you could have a really small leg length discrepancy. So I put these in red because it's important to know that clubfoot is actually a whole leg thing. It's not just a foot problem. It's a whole leg. The whole leg's affected. So classifications, they really aren't important unless you're doing research. It's just to help with outcomes, but This is the Demeglio classification. It just helps with research. It's really unimportant. And then your imaging, there's really no imaging required to diagnose club foot. Okay, you don't have to get any x-rays. You don't have to do anything about the feet. Sometimes you can get an x-ray at 4 months just to make sure that the deformity is going away or to look for residual deformity. And they might have some prognostic value. Some literature out there says that x-ray has prognostic value, but essentially you don't need an x-ray for club feet. And then there's untreated club foot. This is the natural course of what happens in these other countries that don't really have, good medical care. It's very rigid. They have a dorsolateral callus, the hyperflex midfoot. And, surprisingly, what they found is these people are very functional. They just walk around on the soil, and they just walk around like that. It's like having a cyme amputation, like where you amputate your foot in the middle of the foot, and then you just walk around on it. That's essentially how functional they are. And usually only the people who live in the city are painful because they're walking on hard sidewalk. But if you're some guy living in, a country that doesn't have sidewalks and you're just walking in the dirt, they walk on like that just fine. And so this is a story. I joined some running cult last year because I wanted to get back in shape. And one of these people has some residual clubfoot deformity. And so we ran this 10-kilometer race. It was like the Chinatown race. And you can't tell, but one of these people has a club foot. If you really look closely, you'll know who it is. But he beat me by 30 minutes. He had a residual clubfoot deformity. He beat me by 30 minutes on this 10-kilometer race. So, these people are really functional, okay? No big deal. This is a treatment algorithm. This is what you want to tell parents when you tell their baby, oh, your baby's got club feet. Now the mom's all concerned, oh my God, they have club foot. Then you're don't worry, Mia Hamm had a club foot. She's an international soccer star. Christy Yamaguchi had a club foot. She's Olympic, Troy Aikman had a club foot. He's NFL quarterback, Hall of Fame. And so what are you going to tell them? You're basically, you're going to say, oh, you're going to need a cast. You have to come back every single week for a cast for 5 to 8 weeks. And then it's basically, you have to tell the mom they have to come back weekly. And you can either begin at birth or just whenever it's stable. You don't have to start right away. From my point of view, it's easier just because the kids are still smaller. They're not kicking you all the time. But then if you start casting at 2 months old, then they're really strong and they're kicking, and then you're trying to put the cast on, but then they're strong now, so it's harder to put on. And then, but 90% of them these days are getting Achilles tenotomy at 6 to 12 weeks old. And then the most important thing, though, you got to tell them they're going to be in these braces until they're 4 years old, it's actually a really arbitrary number. The guy Ponzetti casting, he just decided to make 4 years the cutoff. But I think it's because from 0 to 5 is the most rapid period of growth in kids, and so your highest chance of recurrence is going to be when you're rapidly growing, right? And so you have to wear these braces until you're 4 years old, unfortunately. But those are the kind of things you want to tell the mom when you tell them their kid's got club foot. They have to see the doctor every week for at least 2 months, and then they might get a small little surgery, and then they're going to be in these braces until they're 4 years old. And then one time I had this, a 13-day-old patient, but it was a 13-year-old mom. So it was a 13-day-old patient, 13-year-old mom, and I had to tell her, you're going to come see me every week. And then she was oh my goodness, right? And so this is kind of what it looks like. You're trying to fix the clubfoot casting. Eventually it comes out again, and that's the tenotomy. Some people do it in the office. Some people do it in the OR because you're 100% sure you did cut the whole thing. It's percutaneous. You just stick the knife in there and just cut. And then they get stuck in these. These are Mitchell shoes and Brown bar. They're stuck in these until they're 4 years old. And there might be a research project out there trying to figure out which club feet you can not do till you're 4 years old. But until that comes out, the kids are in there till they're 4 years old. Okay. And so take-home points: club foot affects your entire leg, right? Basically, Ponzetti casting. Casting just is the gold standard treatment right now. It was accepted in the 1990s. Back in the 1970s, they were telling you have to do surgery. You can't do casting, but now it's 2019. We've been doing casting since 1990, okay? I would tell the parents they need weekly visits, and then they're going to wear a brace until they're 4 years old. And then about 30% of these kids get this dynamic supination. That's when they walk, their big toe kind of their entire foot kind of supinates. while they walk. So dynamic supination. So 30% people might need surgery when they're like 4 years old because the club foot kind of comes back. Surgical treatment, this is surgery. This is why we cast, because, I mean, this is cool to do, but I don't think any mom wants their kid to have surgery like this. And you only have to do it if it fails, or if you have sometimes syndromic neuropathic feet or the delayed presentation. And then it's really just a la carte. It's like dim sum. You just pick which tendons are tight, and then you just cut it. All right? Sometimes you put a pin in it, sometimes you don't. And then you have these sequelae. These things happen to the club foot, midfoot adduction, supination, dorsal bunion, navicular dislocation, valgus hind. These things can happen. You don't want it to, but sometimes when the club foot comes back, you get this midfoot adduction, you get that dorsal bunion, forefoot supination I was talking about. If you're really aggressive with your casting, you can mess up. This happens, and then you turn your club foot into like a vertical talus almost. Try not to have this happen. And sometimes they get this valgus hindfoot if you like overcorrect the subtalar joint while you're doing club feet. And then sometimes they continually internal rotation. But they'll grow out of that. And then these are, you have an idiopathic club foot, but these are a bunch of syndromic club feet where, there are a bunch of syndromes where you'll see club feet. So that's pretty much club foot. This is just an example. This kid has spina bifida, very cute spina bifida feet. They had club foot casting. Then it came back because they did a percutaneous tenotomy. Then you just recast them. And for recurrence after club feet, it's just more casting. Cast again. And you can see it's a lot better. The left is what he was after casting. The right is his recurrence. And then you have to do surgery. For spina bifida, it's different. You have to take a whole chunk of Achilles tendon out, like a whole centimeter, and not just anything else. That's pretty much it. This is some kid with neuromuscular feet. You can see the toes are white. When you're casting, you don't want those toes to be white. You see the toes are like white? If you put a cast on, you notice the toes are white, take the cast off. It means like you overcorrected and there's no blood going to the foot. You don't want that to happen. Okay? And that's it. And there's a bunch of congenital foot deformities, but yeah, for time's sake, we'll just not do that. All right? And that's club foot.